Good morning, everyone, and thank you so much for joining us on this organized session. It's Decolonizing Health Economics, and we have 4 presenters. One of the things we'd like you to do for us is to just put in the chat your name and where you're coming from and the country you're also working from. That will be very nice. We'll have 4 presentations in all. We'll have 2 to start, and then we'll have a Q&A for 10 minutes. And then we'll have the last 2 presentations, and then we'll have another Q&A for 10 minutes, and we'll wrap up. I will give a brief introduction to all our presenters, and then they will start right away. So I'm the chair of this session. I'm Amma Feni. I'm a senior research fellow and a health economist at the Institute of Statistical, Social and Economic Research, University of Ghana. I have my co-chair and discussant with me, Wei Han, who is also a health economist from the World Bank, Beijing, China. Our first presenter is Prof. John Ataguba. He's a professor and director of the Health Economics Unit of Public Health and Family Medicine in the University of Cape Town, South Africa. Our second presenter is Linda Sandick. She is a PhD student with the London School of Hygiene and Tropical Medicine, and she's a health economist with the Malawi Liverpool Wellcome Trust Clinical Research Program. Our third presenter is Prof. Kara Hansen. She's a professor of health system economics and dean of the Faculty of Public Health and Policy, London School of Hygiene and Tropical Medicine. Then our final presenter is Prof. Edwin Barasa. He's the director of the Nairobi program of KEMRI Wellcome Trust Research Program and also heads the program's Health Economics Research Unit. So we will start with Prof. John Ataguba. Thank you very much.
Thank you very much, Amma, for that warm introduction. And I want to gladly welcome you all to this presentation. Today, we will be taking you through on a tour of decolonizing health economics. My talk is giving an overview of where we are at in terms of decolonizing health economics and what we need to do and where we need to go from here. So basically, what I will touch on, my colleagues will take it off from there and dig deeper into the various arms that I will introduce. Great. So what is it about decolonizing health economics? We know from the history of health economics that we can trace these to the major founding fathers, for example, Kenneth Arrow, when he published his seminal work in 1963. And over time, there has been some kind of change in the face of health economics with more women coming on board and other genders also being represented. However, there is still a long way to go. We need to further decolonize health economics, especially looking at representation of Global South researchers and academics. That is a very important aspect that we should begin to look at because health economics is still predominantly driven by the Global North. Unfortunately, I would say that the face of health economics is still related to power and resources. So those that have power and resources drive health economics till date. I will introduce you to the 3 broad areas of teaching and learning, research, and policy advice. And these areas, like I said earlier, will be taken deeper by my colleagues who would do this in turn. For teaching health economics, most of these textbooks that we have been using over the years have come predominantly from the Global South, from the Global North, rather. There are very, very few textbooks that have come from the Global South. And this even includes textbooks that purportedly cover issues of health economics for developing countries. So health economics for developing countries are basically written by researchers from the Global North. And an important question that I think we need to answer at the end of this is, whose health economics is it? If you move again to research and you take a quick look at academic journals, which we see as an avenue for cutting-edge research, what we know is that most of the editorial board members come from the global north, with the global south not being represented. If you take a look at the major journals in health economics, you would see that Africa and Asia, for example, are very underrepresented on the editorial board if you compare that with the population distribution for these regions. So unfortunately, this is something that we need to address. Researchers are heavily underrepresented even in research output, which we already know. Now, if you come again, take a quick look at journals that are supposed to be Asian journals or African journals, and you consider, for example, a journal called the Journal of African Economists. There are only very few Africans or researchers from Africa sitting on the editorial board of a journal that is for African economists. But you would not see the same happening for a journal that is for American economists or for European economists. And then this begs a very big question that needs answer, is who then dictates what is the agenda for Africa or Asia or the developing countries? So the question is, do we really need researchers from the global north to approve research from the global south? And why must this be the case? With Africa being torn apart by different people from different angles, but not so much about Africans themselves, for example, shaping their own future. And if you move to policy, the global south researchers that we know are not adequately represented in policy advice, even within developing countries. You have experts that come from developed countries to advise developing countries. Another angle to colonization of health economics as a discipline itself is evident in how the profession may be seen as a hodgepodge. There is this recent WHO Council on Economics for Health for All, for example. That council that should be looking at health economics is an admixture of basic economists and other health professionals that maybe put together should be equal to health economics, or people who do economics for health. Again, it's another form of decolonizing coming out there. So how then do we move from here? We need to answer the fundamental question I raised earlier. Whose health economics is it? We need to change the narrative deliberately. For teaching and health economics curriculum, this should be context specific as much as possible. And for Global South researchers, we need to define our own agenda and set genuine goals for us as researchers within the Global South to be able to advance research, teaching, and policy advice as well. And paying for publications is another double jeopardy for developing country researchers. One, they cannot afford to pay for such, and also they even struggle to lead such publications. So every angle is basically double jeopardy for them. And for policy advice, we need to change the imbalance and the narrative and allow Global North researchers and policymakers to lead Global South and to learn from the Global South and vice versa. So Global North will learn from Global South, and Global South will learn from the Global North. There are things to cross-learn there. If you take the current move for randomized control trial, for example, most of these trials are designed in the Global North, but tried out in the Global South. Why should this be the case? We can learn from IHEA to ensure global representation on boards, advisory committees, among others. And this, I would argue, is one way to begin to think of how to critically decolonize health economics. And with that, I would want to thank you, and I will hand the baton over to Amma. Thank you.
Thank you very much, Prof. John Ataguba, for this overview of what we will be doing in this session. You have really laid the foundation for what Linda is going to share with us next. So Linda, if you're ready, can you share your screen? Thank you.
Thank you very much, Amma. Second, please.
So whilst Linda is getting ready, please, if you have any questions, please drop them in the chat box. We'll have a Q&A session after Linda's presentation. Thank you.
Right, thank you. Today I'll be presenting on decolonizing economic evaluations in low and middle income countries, asking the main question of what can we do differently. I'd like to acknowledge Sedona and Kazina for their contribution to this presentation. As we are all aware, economic evaluations are important for informing efficient resource allocation. And unfortunately, approaches to economic evaluation as well as use of the same in decision-making tend to be different between high-income countries and low and middle-income countries. In this presentation, we're asking questions around economic evaluations in LMIC as well as just general collaborations. We have four main questions that we're posing for researchers that work in economic evaluations. The first one is, whose priorities are we informing with our findings? The key thing is that if we don't work with local policymakers, we're going to struggle to have their buy-in when we have our findings. And the second question we're asking is, are the findings within the reach of local policymakers? And how can we handle issues of data scarcity, as well as how can we handle skill and capacity issues? Just to say that I'm presenting from a conference room in my office with a lot of people moving around. I'm sorry for noise in the background. The first question that we're posing has to do with priorities in economic evaluation. Basically, LMICs face additional challenges, balancing national priorities as well as funders' interests, while at the same time using very limited resources. Lately and increasingly, more funding agencies are calling for increased use of economic analysis in decision making. But unfortunately, with this, we have an obligation as health economists to consider national priorities. And we thought it's important question we're answering as we're working on economic evaluations, and whose priorities we are actually informing with our findings. Are those the national priorities or the funders' priorities? And finally, for whatever we're doing, any recommendations we have, can local policymakers do anything about the findings? In such settings, the opportunity cost to resources is even higher, and it's important when we are proposing policy interventions to be scaled up, for example, that we actually ask the hard question of whose agenda we're pushing forward with our findings. The second question has to do with usability as well as applicability findings to the local context. The first thing is, are we packaging our results in a way that can easily be used by local policymakers and implementers, and our recommendations even within the remit of the local government? With this, we also have to ask how we can encourage evidence-based decision-making. There's a concern that public health in LMIC there's a tendency not to use evidence from economic evaluation. And the question is, how can we encourage evidence-based decision-making? How far are we putting in effort to translate our research into policy? Are we thinking beyond the number of publications we get from the work? Have we involved local ministries as well as local implementers in our technical working groups in our research? Did we involve them when we are coming up with our research questions and design? And have we involved them when we're implementing research? And finally, have we presented our findings to them? Are they available for them to use? And one thing when we have interventions, we tend, on the recommendations, we tend to encourage scale up. But when we're thinking about LMICs, it's also important to give them a context of the scale up, to actually cause the scale up, to illustrate the resource burdens or resource implications with the scale up. The third issue, or the third question that we're asking, has to do with data scarcity. When we're thinking about economic evaluations in LMICs, they do involve quite a lot more assumptions and data imputations when we're comparing with high-income countries. But aside from this, they tend to be very labor intensive and involve quite a lot of bottom-up costing. And it is important when we are doing, when we're working in this setting to often implement as local ministries, people working in the local settings, they have some form of cost that they use for budgeting, to inform budgeting, and they have those available. So it is important when we're working in LMICs to actually involve more LMIC researchers as well as experts. But also, just before we do costings, to do some literature review for existing cost data instead of, for example, the first thing using price data from global websites. And the additional things we can think through when we're thinking of data scarcity is just think of if we can push for implementers to incorporate standardized extractable cost tracking in their routine data systems, and just think through how ministries can be better equipped for routine cost data collection when you're thinking of cost data, as well as how just exploring additional data transferability options between settings and appropriate ones. And one of the challenges is the issue of tariffs when you're thinking of quality of life measures. Maybe it's high time we actually did more work to develop or to apply for additional grants and collaborations to develop tariffs. There's work that is already happening in Africa, in Uganda and Malawi, just to mention a few. But it may be time we actually did more work to develop additional tariff. And the final question we're asking is on capacity development. There's some LMICs, academic institutions, as well as research institutions that need capacity development. And we should be asking ourselves how deliberate we are in developing capacity. The easiest way would be sending overseas consultants to come and supervise local data collectors. But how sustainable is that? I think we could be more strategic to train a sustainable workforce in LMICs, and also support postgraduate education for low LMIC staff, include that maybe in our grant writing. So with a long-term view of developing global health economic practice and theories to LMICs. In general, it is also important when you're thinking about capacity development to acknowledge the mutual gain that comes, that there's learning that can happen from north to south and south to north. And it is important that we are aware and recognize this opportunity for mutual gain and also acknowledge it. But there's also a need, aside from the fact of the existence of mutual gain, there's also a need for a deliberate and strategic plan of action for building economic evaluation institutions in LMICs. Thank you.
Thank you very much, Linda, for sharing your presentation with us. At this point, I'm going to hand over to Wei to take us through 10 minutes of discussions, questions to all our presenters as well. Thank you.
Hello, everyone, and thanks, John and Linda's presentation. John's presentation provided an overview of where we are in decolonizing health economics, using some simple but really striking examples, such as editorial board membership of some top journals. And John's presentation clearly shows to what extent health economics is driven by those with resources, but not really where the needs are the greatest. I really appreciate the questions John put forward to close the current gaps and approach where we need to be. That is, whose health economics is it? John, I have a question for you. You mentioned that we need to change the imbalance between the global northerners and the global southerners in research, teaching, policy advisory, and implementation. What's in your mind? What might be the top 3 potential entry points or actions we could start to take now or in the near future in changing this imbalance?
Chair, can I go?
Yes, please. John.
Thank you. Thanks so much, Wei. You asked me for 3 entry points. I mean, in terms of changing the imbalance. Many of them, but let me take maybe one for teaching, one for research, and one for policy. It's easier to go that way. Now, in terms of teaching, one entry point is the curriculum that we use for developing countries, or whichever country it is, not just restricted to developing countries, should be context specific. It should be able to address the needs of the population, as opposed to how it is currently designed, where you learn what happens in the USA, for example, or in Canada or in Australia, without really learning so much about what happens your next door neighbor in Malawi, for example. And I tell you, in many African countries, if you call up any African who's gone through any graduate study in health economics, and you ask the person, tell me more about the health system in Angola, the person will be very unlikely to tell you much about Angola, as they will about America or UK or Canada, etc. So that's one entry point. And then the other one for research is to ensure that when we do research, we should mandate as much as possible that developing country researchers should take the lead role in every research that comes out of developing countries. It's very unlikely that the research coming from Canada or America will be spearheaded by a Ghanaian. It's very unlikely, sitting in Ghana, for example. So why is it that it doesn't happen the other way around? Then for policy advice, we know our context very well. So when policy committees are being set up, high-level policy committees, instead of looking for someone coming in from the global north, you could have, even if it is not within your country, your next door neighbor, you could have someone who is well knowledgeable in that field, and you could invite the person to share experiences. We need to learn from ourselves rather than learning from abroad, if that makes sense. Thanks, Wei. I hope I answered the question.
Thanks, John. Linda's presentation taking economics evaluation in a low and a middle income country as the example, and then they laid out the challenges and the priorities in this area facing by low and middle income countries. I would like to summarize into 2 words. One is ownership, the other is capacity. We need local policymakers to own the questions and the fundings. And then we also need to pay high attention to build up local capacity. So Linda, in your presentation, you mentioned that we should support postgraduate education for junior low and middle income staff with a long-term view of developing global health economic practice, and the theory to low and middle income countries. Could you please further elaborate these points, particularly on how to enforce long-term view in practice? My concern is the enforcement of any long-term view requires strong policy commitments from the government as well as funding agencies, which is rare in reality. Over to you, Linda.
Thank you, Wei. That's a good and valid point. That is true. One of the things as a health economist is just to think through the role, how we can work more with the ministries in terms of capacity development, how we can engage the local ministries with this long-term view, and also maybe how IHEA as an institution can be engaged more or involved more in long-term capacity development. But that's more of the broader, bigger issue. But there's something else that can be done at a lower level when we're thinking about the existing research institutions that have existing collaborations, for example, with institutions that are based in the global north. And it can start from such a low level where when we're thinking about the funding, the grant application, we are more deliberate in including PhDs, for example, in those fundings, and PhDs from the countries that we'll be working in, while at the same time we're engaging the ministries we're getting the buy-in in training the local capacity. So it can be both ways, but the idea right now is to just think through what we as researchers in our capacity can do, given whatever resources we have at the moment.
Thank you, Linda, for your elaboration. We have related questions in this regard. One of the questions from our audience is to ask, many low and middle income country researchers and students come to work in high income countries. Do they have an important role in decolonizing health economics? And what's your views? John and Linda, please.
Yeah, thanks. A very, very interesting question there from Ika. I think it's spot on. I'm sorry, from Harriet. The issue is that sometimes many researchers or students from high-income countries come to low and middle-income countries to get what they call low-income country experience. And that gives them leeway and opportunities to get into many of the developing like international organizations like World Bank, WHO, IMF, etc., because that's where many of these researchers want you to have experience. But because they tend to have upper hand, they come to many of these developing countries, get that experience, and they're more likely in terms of propensity to get into many of these international organizations. One, they have got the degree, they've got the experience working in developing countries, and they fly. So they have a motive that is underlying they're coming to supposedly help developing countries. Because in the end, when they go, there is no capacity development. It's a matter of them going away with the experience to move them to where they want to be. It's like targeting, gaming, if you might want to use the word. Well, my 10 cents, thanks.
I would think about it as well in terms of, if I move beyond economic evaluation, one of the easiest way to actually involve them in this sense would be teaching. If LMICs had honorary position for, let's say, health economists who are from there but are based in larger institutions, and just getting them involved in the development of the curricula, and teaching to help in the issue of decolonizing, because right now when we think through our teaching, as John rightly put it, it's mostly we adopt curriculums from the global north, and there's nothing intrinsically wrong about that, but we need additional elements from the global south, and getting people who are trained in the global south, who have gone through those curricula, and bringing them in, and they're also familiar with the local context, getting them more engaged would help with decolonizing, for example. I hope I've addressed that.
Thank you, Linda and John, for your reply. And there's the last question in this session. I think it's related to IHEA. So one of the questions from our audience is basically to ask IHEA asked all abstract submitters to indicate if this research involved primary data collections, and if so, if the presenters of the research was from the country where the data collected. So this was an explicit attempt to do away with the practice of local researchers being seen as data collectors. So do you think this has made any difference in reality compared to previous IHEA congresses? So basically to see whether IHEA, what's the role of IHEA, whether it is a small step forward or what else it can be done.
Let me go quickly again before Linda comes in. It's a very good question there. It was a response from Dai, and she went further to pose that question. I would answer that it might be too early. We're still in it, so it might be difficult at this moment to say for certain and the extent to which that has had an impact. But in principle, let's analyze that in principle. In principle, it has an impact because it begins to recognize the fact that knowledge production doesn't sit in one area. And we need to understand the different aspects of knowledge production and where they come from. Everything is embedded in different contexts. So there is explanation behind every context. So if you cut out a particular context, then you have a misrepresentation of an idea. Over the years, developing countries have not been able to air their voice. Their voice is masked in the global discourse without the nuances that we have to bring to bear. So in principle, yes, but we're yet to see the statistics, which will beg IHEA at the end of this to kind of also show us the statistics. Thanks.
On a personal level, sorry. On a personal level, when I saw that, I actually appreciated it. As somebody who is based in a low-income country and has been working in a low-income country, that was a good initiative. And it was very encouraging. And I remember when we were submitting some abstracts, we had to ask the hard questions as part of the work that we're doing as a group, as a team. We had to ask the hard questions to say, who is actually going to lead on this abstract, and how is it looking to have, for example, a session maybe of work being done in Africa, and almost every presenter is from the North. So we had to ask those hard questions, and I'm sure we're not the only ones that were asking those hard questions. So I think it is a good start, and it was really nice to see and encouraging. We hope it continues, but as John said, in the long term, yeah, we'll see how it goes. But for a start, that was really encouraging. Thanks.
Thanks, Linda. So I think this is end of this Q&A due to the time constraint. I saw lots of questions coming. We may reply and discuss some of in the next Q&A session. Thank you.
Thank you very much, Wei, and our two presenters, John and Linda. We're going to move quickly to the next presentation by Kara Hansen, and it will be followed by Edwin Barasas. Thank you very much. Kara.
There, okay, great, sorry. Thank you very much, Amma. And I first have to say that I'm really honored to be invited to join this panel, because I'm particularly acutely aware of my position as a northern researcher. I'm Canadian. I have worked in the UK for all of my career, and I've built my career on doing research in the global south. So I just wanted to kind of acknowledge my position there. So I'm going to talk a little bit about partnerships, and research partnerships are not specific to health economics, but I think some of, okay, thank you. How do I get rid of?
Just choose use slideshow at the top of the page. Should work. Nope, that didn't work. There we go. Is
that better?
Sorry, now it's disappeared.
Let me try again. Sorry. That. How's that now?
Looks
okay.
Perfect.
Thank you. So as I said, these partnership issues are not exclusive to health economics, but they're very manifest in health economics. So I wanted to start with some data. So this is data that come from a study that Catherine Pitt, a colleague of mine at LSHTM, did, which was a bibliometric analysis of economic evaluations. And so a bibliometric analysis is quite different from a systematic review. It treats the articles as the data. So what she did was to extract from a number of databases the full set of economic evaluations, full economic evaluations that had been published in just over 2 years, 2012 to 2014. And here, so on the vertical axis is the place where the study is looking at. So it's the countries studied. And on the horizontal axis is the income group of the author's country affiliations. So these are divided by World Bank groupings, low, lower, middle, upper, middle, and high, and for both the authors and these are authors' affiliations, as the affiliation that's given on the paper. And that raises one particular question, I suppose. And I think what's really interesting here is some of the detail about the composition of authorship for these economic evaluations. So altogether, 91% of papers had an author from a high-income country. Now, for those studies that were looking at upper middle income countries, 86% of them had an author from an upper middle income country. But only just over half of studies that were looking at low or lower middle income countries had an author from a low or lower middle income country. And in fact, what was interesting is that for those countries that looked at low income countries, 94% of them had an author from a high income country. So I think it's quite, now there's some complications in interpretation, because it may well be that nationals of low and middle income countries had affiliations with high income country institutions because they were working there or because they were studying there. There's a little bit of misclassification, but I think that paints a pretty interesting picture of one of the manifestations of unequal partnerships in health economics research. So what's driving this? So funders play a role. This is a recent letter published in Nature about the award of a large US government grant to look at malaria that was given to a consortium of all high-income countries to support African countries in the use of data for decision-making and malaria control intervention. This is not an uncommon thing that the funders themselves are driving this focus of resources into Northern institutions. But it's not all up to, and I would say that some funders are really changing as well. It's been very interesting to watch in the last couple of rounds of funding requests from the National Institute of Health Research here in the UK, their global health research program. They are really driving change in equitable partnerships. But they're partly responsible. They are changing, but it's not just the funders that are the problem, is it? And I think that we need, as researchers from the global north, to really think hard about what's our role in sustaining these inequities that produce the sorts of authorship patterns that I just spoke about. So whose questions are driving the agenda? Both speakers before have asked this. How are the resources shared? But also, how are the other benefits of the research being shared? Data ownership, the opportunity to present results at meetings, leading the higher profile cross-country analysis when you've got multi-country studies, and of course, authorship roles. So what I'd say is I think it's actually a really exciting time to be thinking about this. It's a really live topic, and there's a lot of good practice being developed and being shared. So this is just a few of the initiatives that are around. We've got the Research Fairness Initiative that has a kind of a reporting guide. There's the Swiss Academy of Sciences that have their guidelines for trans-global research partnerships, the Canadian Coalition for Global Health Research, a whole set of resources. And the UK Collaborative for Development Research has a whole hub of resources for looking at partnerships and assessing partnerships. But I think, and probably the most important thing that's coming out of these guidance is the need to build in equitable distribution of responsibility, power, and authority from the very beginning. So from the point of even beginning to ask a researcher question, that becomes a shared agenda and not dominated by the researchers from the global north. But I think it's also quite interesting to reflect on what are some of the constraints to change. So it really does involve a changing role for Northern investigators and institutions. It's a redistribution of resources. It's a redistribution of authority and power. I would say, just from my own perspective, sometimes the problems aren't the academics, it's the kind of administrative structures. And that can be the funders' administrative structures that require certain systems of accountability and due diligence. But I would say even my own colleagues who work in some of the central departments they're not quite on the same program as researchers are of reflecting and redistributing power and authority. So that's, issues of our default for data ownership is always that we own the data, and it can be challenged and changed, but it's that default position that's really problematic. And similarly with sort of the nature of discussions around contracts. I think there are ongoing considerations of the research support systems in Southern universities. And so the answer there is obviously not to never have Southern universities leading, but to build into the program of work, not just research capacity development and support, but also support to developing the systems to be able to undertake the administration of large and complex grants. And just more generally, I think we just need to adapt and develop new rules that are really consistent with the principles of equitable sharing of opportunities and benefits. And so I didn't realize that I was going to ask that question about IHEA's efforts to encourage representation in conference proceedings, and that's a really great initiative. And it'll be really interesting to assess what impact that's had. It's a little harder to tell when we're not actually physically face to face. I'll look forward to being in Cape Town in 2023 to see how that principle, that research that involves data should be presented by presenters from that country, and how that changes the composition of conference attendance. But I wonder about publications. Journals maybe should just refuse to publish research on low and middle income countries without an author from a low and middle income country. And that would get rid of some of those patterns that we saw in those earlier data. I think it'd be great to hear some more examples and ideas from the audience. Thank you very much.
Thank you very much, Kara, for this wonderful presentation and all the ideas you have thrown for us to think about. A lot to think about this morning. Thank you. So quickly, I'll ask Edwin Barasa to share his slides and start his presentation. Thank you.
Thank you, Amma. So I'm going to talk about the coloniality of health financing reforms in Africa. And the idea is that I will start by quickly introducing the concept of coloniality, and then I will make an argument that health financing reforms as introduced in Africa characterize coloniality, and provide two examples, and there are multiple examples beyond those two, but I'll focus on those two. Then I'll talk a little bit about what I believe to be the root causes, and then talk about a way forward. So with regards to concepts, so the concept here really is a concept of coloniality, and coloniality refers to the manner in which colonialism continues to sustain itself despite the so-called freedoms that African countries gained after independence. And it's essentially the long-standing patterns of power that emerged from colonialism and continue to define the way the world is laid out, the way the world is run and governed, and so on. And there are three main strands of coloniality. One is a coloniality of being, which is this idea that Africans and essentially countries and peoples that were previously colonized were dehumanized. There's also the coloniality of power, which is a control of economies, authority, sexuality, subjectivity, and knowledge. And here I will focus on the coloniality of economies. And lastly, the coloniality of knowledge, which is a marginalization of African forms of knowledge and privilege, the knowledge of the conceptual West, which sometimes has been referred to as epistemological colonization. So I'm going to focus on the latter two, so coloniality of power and coloniality of knowledge. One of the leading discussants or authors around coloniality from Africa say that the worst form of colonization that has continued to wreak havoc on the continent is the epistemological one. This is a colonization of imagination and the mind that is often hidden in institutions and discourses that govern the modern world. So here the argument really is that international development as currently structured is anchored in colonialism, where Western-centric forms of knowledge are considered as the standard against which other forms of non-Western thinking and people are judged. And the way in which international development influences health financing reforms in Africa manifests this coloniality. And here the focus is on the coloniality of power, so that is the economic kind, and the one of knowledge. A key outcome of this coloniality is really the introduction of health financing reforms that are not aligned with the African context, ignore the African context, and therefore compromise health system goals. So they go against what they were intended to achieve in the first place. So the first exhibit is social health insurance reform. Several African countries have introduced social health insurance as a mechanism to either mobilize, to mobilize additional resources for the health sector and to purchase. These reforms are typically supported by external development partners and are framed as replacement for user. Ironically, as you know, user fees were also introduced by the same international development partners. This mechanism, this is social health insurance, ignores the contextual reality of the African continent. The fact that most of the continent, the labor market is typically informal, it's mostly poor, and there are weak social protection systems, so the information systems and so on, which essentially lead to low coverage, high inequality, and inefficient allocation of resources. So we did a study looking at health insurance coverage across Africa, and what we found is that only about 4 countries have health insurance coverage above 20%. And we also found that inequality in health insurance coverage was quite high. So essentially, the upper quintile had 4 times more coverage compared to the lower quintile. So this clearly shows that social health insurance as a mechanism is not working very well in Africa because of the contextual reality of the continent. And yet it is being pushed quite aggressively as a viable health financing mechanism. The other example of a health financing reform that's characterized by coloniality is performance-based financing. We know that this is a mechanism that incentivizes health providers, incentivizes health providers to either increase outputs or increase quality and provides financial incentives for it. Again, over the past couple of years, PBF as a mechanism has really, PBF projects have really increased in Africa, and this has been attributed to strong advocacy by international partners, international agencies. So we did a literature review to look at the experience of PBF across the African continent, and this literature review is representative of 24 African countries. And we found that PBF is externally driven. So PBF introduction in Africa has majorly been advocated by external international partners. It's typically characterized by a top-down implementation that often ignores or sidelines local actors, and the interests of national actors are often distorted, devaluing the role of national policymakers. An example is the experience of Cameroon, for instance. The other thing is that PBF tends to ignore the context of health system capacity. So there was this concern that PBF is introduced in settings where health facilities are significantly underfunded and have challenges providing essential healthcare commodities. The idea is that PBF should incentivize increased use and quality, while the underlying system to provide essential services is compromised. So someone from Zambia once said that PBF should be the cherry on the cake. How can you have the cherry when the cake is not there? PBF tends to ignore the socioeconomic context. So you have PBF being introduced in contexts that are predominantly poor, with challenges with access and access to healthcare facilities and so on. And so while PBF incentivizes access, it ignores the fact that there are other access barriers that are not being factored in the solution that's being provided. PBF as an intervention has also been characterized by ignoring broader health system context. So PBF is typically not aligned to the broader health system structures. It is often introduced in settings where there is no financial autonomy, which goes against how PBF should work. It is often implemented as an add-on to existing financing mechanisms rather than being integrated to these mechanisms. So it is added on to line budgets rather than replacing or transitioning line budgets into output-based mechanisms. It's not conscious of the conflict in different financial mechanisms. So it's implemented in settings where you have out-of-pocket payments, and it is often introduced as a parallel accountability mechanism with parallel agencies that lead to duplication and confusion. And so the outcome for PBF has essentially been mixed findings in terms of effectiveness. There has been low country support and ownership, which has threatened its compromises financial sustainability. It has focused policy dialogue away from other processes of change. It has been rarely integrated to the main system and rarely scaled up, and it has had unintended health system consequences such as crowding out and incentivized services. So why do African governments allow this? There's a twin problem. One, over time, the African continent has been characterized by poor governance, which has in turn led to aid dependence that has robbed Africa its agency. One of the elders in health systems in Africa made this quote in his book that essentially says that Africans went to Bretton Woods institutions and to other institutions and countries begging for advice and for money, and we got both. but in exchange for certain core values, Africans lost self-respect, self-confidence, and self-determination. And so as a result, Africa has a mindset problem. There's a sense in which Africa has externalized problem solving and accountability for actions. And external partners have taken advantage of this and perpetuated this coloniality. So how do we move forward? The first is to decolonize the mind. We need decolonial epistemic perspectives that critically reflect on and reveal the coloniality that is embedded in externally driven health financing reforms. We also need to restructure the way African governments engage with external partners to reclaim African government's role as a leader and a steward in health policy and systems reform. And we also need to ensure that health policy and reform priorities are country-led and context appropriate, and that the role of external partners remains supportive rather than taking a leadership role. And of course, we need to nurture a mindset, a change of mindsets from donor dependence to progressive self-reliance and self-determination. Thank you.
Thank you very much, Edwin. This is really good information for us to deliberate on in the next 6 minutes. I'll ask Wei to take over from here. Thanks.
Thanks, both of the presenters, Kara and Edwin. Starting from Edwin, because I have, I'll take advantage as I am self as the co-chair of this moderator of this session. So Edwin, I have a quick reflection on what you are discussing about on the health financing reforms in African countries. As far as I understood, for the projects supported by some international development organizations, the PBF reforms is often introduced as one of the intervention in an intervention package. It is combined with other interventions that address the access barriers, such as infrastructure, construction, equipment purchasing, or training. So if it's not, they are not doing well so far. They didn't supply what is really needed in African countries. So from your perspective, what actions the international organizations should take to improve the current situation at the current stage? The way forward you proposed is more about medium to long-term goals. I'm more interested in concrete short-term actions that would lead to a change of the mindset of the government or change of the government engagement. Over to you, Edwin.
Thanks, Wei. So there's a difference between what appears on paper and what happens in practice. And in practice, what happens is that a lot of the interventions that are introduced, especially in an intervention like PBF, for instance, are introduced as vertical and parallel to the system. And so even when development partners talk about, sort of expanding their approach to include system support, what they actually mean is system support within the confines of the project that they're implementing. And their definition of systems is quite sort of, it's quite constrained. So the boundaries around the system are quite small so that the rest of the system is often ignored. So what should development partners do? I think it's a dual role. It's not just about development partners, right? What you're talking about is, number one, for them to cede the leadership role to allow government to take a leadership role in guiding these reforms. Now, the discussions between development partners and governments in defining reforms should have a whole systems approach rather than a narrow verticalized approach. So if you want, for instance, to introduce a provider payment mechanism, the question to ask is, what are you solving for? Are you testing a fancy mechanism, or are you solving a broader problem? If the problem is quality or reduced access, the question is, what is the root cause of that quality problem or access problem? Once you have a whole system view of what the problem is, then the solutions will become more clear, and the solutions will incorporate, broader health system interventions.
Thank you, Edwin. I think from my perspective, my real practical working experience, what we trying to solve, I mean, not in African countries, but we do ensure we take a whole system approach, health system approach That's why I was saying in the overall, most of the projects we developed, we try to solve the problem, not only in health financing reform itself, but combined with other demand, other supply side interventions. Okay, I think we need to move fast. Kara, and a question for you from the audience is asking you about about how to go through the institutional barriers. Have you made any effort or any successful experience in these to share equitable partnership with other research teams?
Thanks, Wei, for the question. I think that might have been from Sedona as well. So we're on a journey at the London School of Hygiene, and it's a journey that's been very much kind of prompted and led by a staff and student group on decolonizing global health. And so they have sort of suggested a whole set of areas of action, and equitable partnerships is one of them. So the practical means of taking that forward is going to be to build on the discussions that have been taking place in research group and department level, and to take that to a school level working group, which will be established in the next couple of months. I think what's really important is that working group needs to involve those who come from the research support department. So people who come from human resources, who come from research operations and contracts. And it's kind of, and for those groups, it's a matter of addressing their understandings of risk. They tend to have a very particular notion of risk, and really getting them to be part of the broader mission of not just the research that we do, but of the decolonizing initiatives. So it's kind of a hearts and minds exercise, which I hope that we'll tackle by having them involved in it. So rather than trying to direct change from above, it's to try to involve them in creating the changes that are needed.
Thank you, Kara. I think our session time ends, but I really have another questions here I put forward, no need to really answer, is how we to make sure the sharing of international best practice doesn't becomes a colonization of health economics or colonization of health policy. The border between these two is not that clear. This is international best practice sharing versus decolonization. So thank you very much. Hopefully you could think through these questions. Thank you.
Thank you very much, Wei, for discussing all the questions. And thank you to our audience for such a great time talking about decolonizing health economics. So whose health economics is it? And who's dictating the health economics agenda? Great questions that have been posed this morning. We've also looked at what COVID-19 will mean for decolonizing health economics, especially when we have a lot of researchers from the global south working hand in hand with a lot of partners across the world to solve the problems of the COVID-19 pandemic. We also take a look at the fact that health system resilience in itself, it's one catalyst to encouraging colonizing of our processes and our policies. So until we look at our health systems and try and make them work better, we'll always go begging for policies, we'll always go begging for agenda. So thank you so much. We were supported greatly on this organized session by Sedona Sweeney, Justine Maya-Rath, and Megan Kumahide. They have been exceptionally wonderfully supporting us to get every information and every group together. So a great thanks to all of them. And I think this will become a paper or a journal or a special issue, and we'll be glad to have more information coming from all of you. And the question to IHEA is, how can you change this decolonizing of health economics? In 2 years, when we meet in Cape Town, we should have made a lot of progress in this regard, and we are holding all of ourselves accountable to this. Thank you so much for joining us for this session. Thank you, everyone.